Right, I think the first question you'd ask yourself if you were going to do stem cell therapy for vein grafting is why on earth do something so complicated to solve such a simple problem? So really my overview is designed to convince you that you really need to do something that complicated. Okay, what's the problem with vein graft occlusion? There are 1 million procedures every year with about 3 veins used in each procedure. About 10% of these veins will occlude in the first few days due to early thrombosis. Another 10% will go in the first year thanks to this intimal thickening process, and a bit more perhaps over the next 5 years. And then because you've got this fat thickened intima, you'll get atheroma in 5% of these for the next 5 years, and so eventually you'll end up with a situation like this, with the thickened intima, a very friable, lipid-rich plaque, a thin fibrous cap, and this is ruptured here in the typical plaque rupture in a vein graft. The result is 50% patency by 12 years and quite a lot of reoperations, so big economic cost. Okay, so this is, what can you do about it? Well, you can use aspirin. So these are ancient trials here. It shows that aspirin roughly halves the rate of immediate thrombosis. And this benefit is carried over to a year, but it's certainly not amplified. It's a problem which affects small grafts, so the sort of things that you have to do nowadays because you're doing all the big ones with arterial conduits. And there doesn't seem to be much attrition actually over up to 3 years in these old trials. So if you do a meta-analysis, you come to the conclusion about 1/3 of the patients would have an occluded graft without aspirin and a 1/5 of patients with aspirin. Now, you could say this is ancient data. Does it have any relevance to what people are doing now? Okay, well, this is a much more recent trial, and I know Johnny thinks that this is criminal, but in this very, very fancy trial here, done in the 107 centers in the US, they had a per graft occlusion rate of 30% and per patient rate of 45%. Well, at least it allowed them to do an analysis of what impact it has on subsequent outcome, and that what they could show is that if you had an occluded graft detected by angiography at a year, you were far more likely then to have an immediate revascularization, or indeed over the next 4 years, have a revascularization. Fortunately for them, didn't really have much impact on death or myocardial infarction. So there you go. So, but it certainly does have an adverse effect. So what can you do about it? Well, one thing is you could try a no-touch technique. This was originally suggested basically on deductive logic by Gottlob in 1977. And Johnny and I produced the first experimental evidence that this was a rational thing to do in a pig model back in 1990. And that led to, well, I don't know whether it led to it, but certainly there were some trials done afterwards. And there are more than 8 trials now. The biggest of the trials is around about 156 patients, so they're not huge trials. And a so-called meta-analysis of these trials in this paper here concluded that there is a benefit on early and late patency. But they said it would be reassuring to see similar results replicated elsewhere, and this heralds the need for a large multi-center study before widespread use can be recommended. Okay, so they'd be very pleased to know that there is a big RCT going on, it's in progress at the moment in Bristol, and I don't know whether John is going to show you any data from that. I don't think so. But it's very soon to be completed, that trial. Okay, most of the effort in this area has gone into trying to reduce this neointima formation problem because it provides the soil for later atherosclerosis and late vein graft failure. You can visualize this, at least the luminal narrowing by CT. You can look at the wall by IVUS. On the basis of this, we know that it's a slow process. It takes at least 3 months to get going. And it's, in some grafts, it's even progressive beyond that. Here's an important dimension. It thickens the vein graft wall from about 0.5 millimeters to 1 millimeter. Okay, bear that in mind. And we're pretty sure that it depends on the migration and proliferation of smooth muscle cells. So in thinking about animal models to do experimental studies, you want a model which does similar things. So Johnny and I invented this model, which is a pig saphenous vein interposed into a segment of the carotid artery. And even in the pig, the vein isn't quite as thick-walled as it is in the human. Obviously, pigs run around on 4 legs, and we stand up on 2, so they don't have such thick walls in their veins. But you can see that the thickening that occurs is progressive over 16 weeks. So that's a rational sort of time frame. And we know that there is a lot of proliferation going on based on this PCNA staining, and there's production of growth factors as well. Okay, so this is a reasonable model. What are the disadvantages of it? Well, the disadvantages, like with all animal models so far developed, we use short, straight, end-to-end anastomoses. And you'll see later that this is a real flaw when it comes to translation. The other big problem with the pig model is that there's little atherosclerosis. Even if, when we did this heroic study where we fed them with 1% cholesterol diet, this was basically kilos and kilos of the wretched stuff, for 3 months we could only get 1.5% of the total cells to be foamy. So that's a disadvantage. So what about using a rodent model? Well, Qingbo Zhu developed a model where he took the mouse vena cava and he put that in as an interposition graft as well. The advantage of this is that it did replicate the long time course. It's relatively cheap, although mice are terribly expensive these days, and you need 2 mice to do this experiment. Big advantage is you can do genetic manipulation, and we're going to hear some things about that. And one of these is you can do it in ApoE mice, so you can get nice big atherosclerotic plaques. This is calcification here. So that's the advantage. What about the disadvantages is? Well, the small size is the main disadvantage. Look, here we are. We've got the wall thickness at the beginning is only 25 microns. This is the time course of increase. That looks rational. But because you've got such a thin wall to start with, by the second day, all of the cells in that vein have died off. They've been stretched to death. So where does the wall thickening come from? Well, Qingbo did a lot of experiments on this, and he said 60% of the cells come from the graft. Okay, so they would be these adventitial cells here migrating in, like adventitial fibroblasts, possibly some pericyte precursors. 40% of the cells come from the host, but goodness knows where from, because they don't come from the bone marrow. And none of this is probably relevant to human grafts. So this is a big disadvantage. Anyway, let's go on to some experiments that we did, which will hope to convince you that these experiments lead us towards doing something as clever as cell therapy. Okay, so we started off trying something simple, basically using an anti-proliferative agent that had proved successful already in stent restenosis, and I'm sure you're all familiar with the mechanism of action of rapamycin, which inhibits mTOR and blocks G1S transition, so it's anti-proliferative and it's very effective here. The other thing you can use is paclitaxel, which is an antimitotic agent. And this paper here showed that if you just pre-treated the cells with paclitaxel, you've got a long duration of effect. So that was another reason why you might think that just treating veins at the time of harvesting with these agents might have a long-term effect on proliferation. And we could show that in the pig model, that a week later, there was still an anti-proliferative effect of these agents. Okay, but when we came to look at wall thickening, which is illustrated here, you can see that we had a big effect. This is rapamycin. Big effect, almost completely blocked wall thickening and neointima formation after 4 weeks. But the vein graft continues to develop in size over the next 8 weeks. That's what those crosses mean. These are significantly more than those. And you can see that although the benefit seems as if it might be preserved, by the end of this experiment there's hardly any difference, and it's certainly not statistically significant. The same thing is true for paclitaxel. You don't get such a good effect initially, but by the end of the 12 weeks it's really gone away. So the difficulty is that the long time course of the development of neointima really works against you when you want to do this kind of acute experiment. Okay, so a variety of local anti-proliferative strategies appear to work in animal models, but you only get short-term effects. Whenever we try long-term follow-up, it doesn't work anymore. We tried a slow-release formulation, but that wasn't any better. So this implies you either need to do systemic therapy, which you can continue, or you need to do gene transfer, which permanently alters the vein graft, or you could do something like a mechanical treatment, and we're going to hear about that in a bit. Or you could do this cell therapy. Okay, so I'm going to go through a couple of these things. a systemic therapy. Here we are, Jamie Jeremy in our group tried a systemic therapy that worked very well, endothelin 1A receptor antagonist. He could show that this would reduce intima formation. At these high doses, it even reduced media formation. And this is probably not a good idea because then the vein just balloons out, and I can show you that because at the high doses, the vein actually distended out in a sort of aneurysmal way. Anyway, despite the very good effects that he got of this agent, we couldn't convince any company that had an ET1A antagonist to participate even in a phase 1 clinical trial with us. And so this has stayed on hold as an idea. If any of you got contacts in the right places, we'd be very happy to hear from you. Another thing we tried was external supports. This is a polyester support. This produced the most dramatic effect on intima formation. So this is an unstented or unsupported graft here with a media and a massive intima, completely reversed by this external support. And we went on to show that you didn't need to have a tight-fitting support. In fact, it actually worked better when the support was bigger, was oversized. So how does it really work? Well, this is the support. And inside the support, a new adventitia grows, and it's full of blood vessels. That's what these lumina are all concerned of. And we noticed this phenomenon. We wondered whether it was really important. And Jamie actually showed that the normal media becomes very hypoxic after implantation, and that this technique reversed that hypoxia. And this is another piece of evidence that this neoadventitia is really important, is if we replace the polyester stent, which is macroporous, with a microporous PTFE stent, then the blood vessels can't migrate in. And you can see there are none of these blood vessels here. And in this situation, you actually get an overproduction of both media and intimal thickening. So in the absence of this adventitia, which feeds the outside of the vessel, things get worse rather than better. Okay, so this looks fantastic. It works really, really well in the animal model. So we translated into a human experiment. Gianni put in loads of these grafts here, along with Gavin Murphy. And we looked at them. The intention was to look at them by IVUS after a few months and to see whether the wall thickening was actually reduced. Unfortunately, when we looked at all this, all of the grafts that we tried to put in were occluded, and so we had to abandon the study. And I think we were very courageous, actually, to publish these results, but we decided we had to for the good of the field. So, a fantastic treatment for a short, straight graft in a pig carotid artery, not translatable into human beings. So, why do I want to do cell therapy? Well, I want to replicate the benefits of the stent, but not using a stent. And I want to do it by sustained delivery of angiogenic factors that's going to produce that neoadventitia and feed oxygen into the graft, but without using a mechanical support. So we had this idea, and of course, all the experiments we'd done with the antiproliferative agents taught us that it had to be done for a long time. You couldn't do it for a short time. So we need something that can sustain this production. So we thought of using cell therapy. And in fact, there was a product on the market called cell beads. And these are microbeads. They're made of alginate, which is the same stuff they put in your mouth when you have a dental impression done. But in this case, the alginate is coated around immortalized human stem cells, which release a number of growth factors. And they've also been genetically modified, so they produce this human GLP-1 protein, which prevents apoptosis. So at the same time, some other workers in Cardiff, Paolo Madidu's group, were studying the same preparation. And they directly showed here that a number of growth factors were produced by these cells. The green ones are the ones without the HGLP-1, and the red ones are the ones with GLP-1. And you can see that they produce a lot of growth factors, and there's not really much difference whether you have the GLP-1 factor or not. Then they implanted these under the skin around the femoral artery before they did a femoral artery occlusion. And they could show that they were pro-angiogenic in vivo in this mouse model. There were an increase in the number of capillaries and arterioles around here. So then they went on to do a typical limb ischemia experiment. So they're looking at the feet here to look if the blood flow is restored. And you can see this is the control. So blood flow is restored a bit, but not optimally. And if you put in the cell beads, either with or without the GLP, then you've got a better restoration of flow into the feet. And you could see that this increased the blood flow, quantified here, and the oxygen tension. But again, you can see that the GLP protein isn't really important for this. So the human mesenchymal stem cells by themselves seem to be enough to do this. Anyway, we had access to the ones which had the GLP in them, and it didn't seem to do any harm, so we carried on. We had 3 groups, a no treatment group, a bead alone group, and then beads which contain the stem cells. And we put them around these interposition grafts in the pigs and harvested them 4 weeks later. This is just really a pilot experiment to see if it would be worth to do a long-term experiment. Okay. And these are the results. First of all, if we just look at the morphology, this is the standard median, nice big neointima. You can see in the treated ones, these are the beads. Okay, these are the empty beads here. These are the cell-containing beads out here. You can immediately see the problem here. There tends to be a little patch of them attaching on here. It's not uniform all the way around, so delivery is obviously an issue that we need to address here. But nevertheless, we could show that the neointimal area was significantly reduced when you had the beads. So this is the control with the empty beads, and this is with the cell beads. And you can see there's a reduction, and it is a statistically significant reduction in the neointimal area, at least at this 4-week time point. Okay, so this also looks like it might be a reduction in the total wall area, which is obviously caused by this reduction here. Okay, so did it actually stimulate angiogenesis? And we could show that it did because we used a stain, which stains for endothelial cells here, and you can see there are all these lumini, particularly when we had the cell beads here. You can see all these open lumens here that's suggesting there is angiogenesis. And when we quantified this, yes, it very significantly increased the number of these. Okay, so it does do it by causing angiogenesis. We also looked at fibrosis, and we could see that the cell beads do generate fibrosis. This is probably a good thing, because if you're reducing the medial thickness and the intimal thickness, you still need to support the graft somehow. And if the adventitia strengthens itself by fibrosis, then that's probably a good thing. And that's significant as well. You can see there's more adventitial fibrosis with the beads. One concern we had was, would the beads cause inflammation? So here we used 3 different stains, one for macrophages, one for lymphocytes, and one for monocytes and granulocytes. These are all pig antibodies here. And we had a control tissue, which was a tonsil taken from a pig. But you could see in the graft, in none of the graft treatments did we see any positive staining for any of these inflammatory cells. So I think we could be fairly conclusive that there's no inflammatory response. It's interesting to note here, these are the empty beads and these are the cell beads, and you can very clearly see that the cells survive beautifully. These are the actual live cells inside the beads. Okay, so the conclusion is that periadventitial human stem cells inhibit neointimal formation, at least at this 4-week time point. They do it by accelerating neoangiogenesis. They also promote fibrosis, and they don't cause inflammation. So I would suggest that translation may be possible, but it requires some more optimization in relation to efficacy, the longevity of the production, and also we need to consider the method of delivery, and that's where we're at the moment, trying to optimize it in this way. So thank you very much for your attention.